Hello, everyone, and welcome to Week 11 of the HSCI 6240. We're focused on health insurance exchanges. I'm going to talk with you about the purpose of the exchanges, key features, governance, state, federal, or both. The purpose is really to provide health insurance to this group of people who are not eligible for Medicaid, but they are not getting insurance from their employers. And we generally think of those people as working poor or lower middle class people. Some of them, as you get higher up in income, would be called middle class, particularly depending on what state you're in. In a state like Arkansas, where I'm from, if you're at 300% of the federal poverty level, you're really not poor. You're probably a middle class person. So it really just depends on where you're living. All right. The key features of the health insurance exchanges are that they are for people of a certain income level, as I just stated. For a single person, 100% of federal poverty level is 11,490. If you go up to 400%, just multiply that by four, you'll get about 44,000, 45,000. So, we're talking about people that many of you would know. These are your relatives. These are people with their first jobs. For some people, it may not. It may be, one of their later jobs. It really just depends on where you are in the country. That could be a lot of money depending on where you are. But in a place like D.C., that's not a terrible amount of money. That's not much money. So that was more like a starting salary for an entry level job around here, an entry level office job. All right. In states that expand Medicaid, they're really going to start their exchange at 139% because that's the that's the level above which there is Medicaid expansion. Medicaid expansion goes up to 138% of federal poverty level. So above that is where the exchange will kick in. For those people who qualify for Medicaid, they cannot participate in the exchange. All right, the exchanges are kind of like a big mall of health plans, as we talked about before. I think in the health reform reading, that federal health reform reading we had in the past, I think I shared that Kaiser Family Foundation video with you. Hopefully, some of you looked at that. Health reform hits Main Street. And in that video, they talk about health insurance exchange plans being like a mall. So, walking into this mall and you're looking around, let's say you're looking around for clothing, and you see all these different stores, and you're trying to figure out which one is suitable for you. So, everyone has a store they like more than others, whether it's, for whatever kind of clothing you're looking for. If you're a guy, maybe it's a certain store you like to get your suits from, or women, it's a certain store you like to get your dresses from, and shoes, and so on. So this is the same thing, but it's just a health insurance plan. You're looking around for what's best for you. You're going to have a variety of different options. Hopefully, in states, some states will have less options than others, of course. Depending on what insurers actually do business in that state. And you're going to choose plans that are right for you. Now, all of these plans will have what's called essential health benefits. That means they all will meet a minimum level of coverage and offer a minimum level of benefits that's required by the federal government. So that's really important. That's something that hasn't been done before by the federal government, and it really adds a sort of a national character to all of these plans and prevents them from being junk health insurance plans. And what I mean by that are plans that offer very little coverage and perhaps charge a premium, but really give people nothing in return for that premium. And so we avoid that problem by indicating what basic benefits these plans have to offer. The plans cannot deny people or kick them off their insurance based on pre-existing conditions. So, in 2014, that's going to be the case for most health plans. That will also apply to the health insurance exchange. For any health insurance company, sorry, that wants to offer health plans in exchange, they're going to have to meet a variety of standards. First, they're going to have to start off meeting state standards. So, any health insurer who does business in a particular state has to meet state standards. States traditionally have regulated health insurance companies. This is usually not something the federal government gets involved in at all. States have a lot of particular rules for their health insurance companies. They have certain things they want them to cover and not cover and things like that. So that, as you can imagine, depending on whether the state is sort of left leaning or right leaning, the pressures or the requirements they place on health insurers are likely to be greater or less. So you first have to meet those state standards. Then after that, you have to meet federal standards that are specifically linked to the health insurance exchanges. And one is this essential health benefits standard, right? So that's not coming from states. That's coming from the federal government. The pre-existing condition clause is being removed. That again is not coming from states. It's coming from the federal government. And there are a host of other requirements, too detailed for a class like this to get into. But just know there are a lot of standards that a health insurer would need to meet. And so this is not an easy task for a health insurer. They have to go through and check a lot of boxes, change their plans as necessary, and really work on trying to figure out what their business model should be in this space. Um, so all of the plans also have to offer a silver and a gold level plan in order to participate in exchange in any state. And here's what I mean by silver and gold level plans. So there are four different levels of plans, and those plans vary based on actuarial value. Actuarial value just refers to the amount of healthcare costs being paid for by the health plan. So the lowest level plan will pay 60% of your healthcare costs. The highest level plan will pay 85% of your healthcare costs. So that's telling you that there's going to be some variation in terms of the type of coverage you're going to get from these plans. That there may be some more gaps in your coverage at a lower level. So at the lower level, you're probably going to pay a lower premium, but you won't get quite as much of your costs taken care of. Depending on what you need, of course. For the higher level plan, you're going to get most of your health care costs taken care of by the insurance plan. All right. Now, let's talk about tax credits. The question for people who are uninsured currently, and in 2014 they're uninsured, is going to be whether or not the tax credits will make these plans affordable enough for them to actually be able to purchase one of the health plans. And they're going to ask, well, if you look at the value of the health plan, you look at the tax credit I'm getting and how affordable it is for me, and then you look at this penalty that I would be charged if I didn't get health insurance, like tax penalty, the individual mandate tax penalty, then which one is higher? So if the tax penalty is going to be much lower, let's say half the cost of paying for the premiums for the health plan, even with the tax credit, then the person might be persuaded to just go with the penalty, depending on who they are. Now, we know that families and people with pre-existing conditions are likely to want insurance, right? So they're unlikely to choose the penalty over getting health insurance because they really want that health insurance. But what about those young people out there who feel like they're invincible, and nothing's going to happen to them, and they're immortal, and so on? Those people may actually go with the penalty instead, and so that sort of remains a question in terms of what kind of decision people are going to make. But it's really all about the tax credits. So what do these tax credits look like? Well, they're based on income, so they're a sliding scale. If you have lower income, you get a higher tax credit. Higher income, you get a lower tax credit. The premiums are set up so that if the amount of money you have to pay, the tax credits are set up so that if the amount of premium you have to pay goes above a certain amount of your income, then you get a tax credit. And how is that structured? So using the second lowest cost silver plan premium as the sort of standard or threshold for a premium, if based on your income the level of premium you have to pay goes a certain amount above this silver plan premium, then that will be your tax credit amount. And I'll explain that again in the future. But basically, just remember that this second lowest cost silver plan premium is the threshold point for determining whether or not you get a certain amount of tax credit. And these tax credits are advanceable, meaning that you get them right away. So when you're paying you don't have to wait until you file your taxes and get the tax credit later on, and write it on your 1040 or something like that. You get the tax credit up front. So when you go in and you pay your premium online or so on, then you see the deduction right away. You don't have to wait on that tax credit. So that's great, and that's really good because the people we're talking about are low income or lower middle income people for the most part. So we want to make sure that we actually help them up front. Otherwise, they're going to be less interested and less incentivized to actually purchase health insurance, right? Uh, Now, what's nice about these tax credits is that they're also available to legal residents. So this is one of the first times that legal residents have had access to some kind of government-sponsored health insurance. So they don't have to wait for a year or 2 or 3 years or so on to get it. They you can utilize it just like everyone else who's a citizen in this country. Now, this will not be available to this group of illegal immigrant students that Obama deferred deportation for. Some of you may have heard about these students. They are people who have been living in the U.S. most of their lives. They came here when they were under 16. They are college students and so on. And they are very American, and deporting them doesn't really make much sense because they really have already contributed to society and look like people who are likely to contribute a lot to society. So, what we like to do is figure out some pathway to citizenship for them, but we don't have good immigration laws in place to actually help those young people. So what Obama has done is actually defer deportation for 2 years so that we can get some laws in place, hopefully through Congress, and hopefully they'll be coming this year, which will actually help these kids get on the road to citizenship. And they're, for better or for worse, these kids are out there and they cannot actually access the health insurance exchange plans. They also can't access Medicaid plans or any other government health insurance plans because they're illegal, right? So they despite this deferral of their deportation, they're not able to get any of these benefits. So just be aware of that for any of you who are concerned about that issue. Okay, so now back to the tax credit. So you take the second lowest cost silver plan premium, multiply that by 12, and that'll give you the total premium for the year. Now you look at your income, you say, okay, is that total premium for the year above 2% of my income if I'm at the 133% federal poverty level? Or if I'm at the 400% federal poverty level, is it above 9.5% of my income? Because that's the maximum that the premium should be for you, right? So this premium as a percent of income, this is the limit for the amount you have to pay. So we don't want people who are at let's say 150% federal poverty level paying 10% of their income to health insurance. Why not? And you might say, well, why not? Hey, if they need it, that's what they ought to pay for it. But we know that actually leads to them not buying it, right? So it's not affordable. They're going to stay away from it. But we prefer for them to have health insurance. Otherwise, they end up in the ER, generating uncompensated care costs, blah blah blah, having poor health outcomes, and so on. So in order to stop that, the approach here is that you offer them a tax credit when you hit a point at which you think healthcare insurance may become unaffordable for them, right? So we think at certain levels, as you move up the income levels, that a higher percentage of your income is likely to be considered uh, unaffordable. And so if you're at 133% the federal poverty level, then 2% of your income is going to seem like just as much as 9.5% of your income at the 400% poverty level. That may or may not be good logic, but that's the approach being used in the Affordable Care Act to determine whether or not you get premiums. And so once we go above that amount, of your that percentage of your income, then you get credits for anything above that amount. Okay. Let me know if you have any questions about that by email. All right. Now, there's also some other subsidies. So there's a cost sharing subsidy. So if you're a family at 250% or and below of the federal poverty level, then what happens to your health plan that you choose is that the actuarial value actually increases, right? And so this is great. So it means basically you get for any cost sharing you have to do, you basically get some assistance, you get some help. So you should have a lower level of cost sharing than people with higher income levels. Okay, so that again is another kind of bonus. Again, it's an incentive to get people to purchase one of these plans. So you can see the various calculations people are likely to have to do in order to figure out, well, is this affordable and is this good for me or not? And the goal here is to try to give people assistance in different ways in order to make these plans affordable for them. Now, finally, there are some out-of-pocket cost limits that will be available to you with the health insurance exchange plan. So, if your income level is at 100% of the federal poverty level, then your out-of-pocket liability is going to only be two-thirds of the maximum amount. If you're at 200% of 250% of the federal poverty level, then your out-of-pocket liability will be one half of the maximum amount. The maximum amount right now comes from the health savings account out-of-pocket limits. So some of you may have heard about these federal health, well, heard about health savings accounts being offered by employers. There are standards created by the federal government for those health savings accounts, and one standard is the out-of-pocket limits. So if you have a health savings account, you also have a type of health plan that has a really low premium. It's made to push people to use their health savings account for their health care instead of using health insurance, and there are out-of-pocket limits for those health plans, and so that's what's being used as the standard for the cost limits here for the health insurance exchange. That's, I know it's a lot of in-depth policy stuff, but just know that there are out-of-pocket cost limits for people who are participating in exchange based on their income level. All right, governance. Now, governance has really been probably the issue that has received the most attention from the media because the federal government really thought that states were going to take on these plans. States of all types, Democrat states, of course, because Democrats are in control in the federal, and at least at the presidential level. And the Affordable Care Act was really a Democrat piece of legislation. So they figured, well, in states with Democratic governors, this would be no problem. They would take it on, and they were right. In states like Maryland, they ran away with this and had a great time developing their state health insurance exchange, and they're just chomping at the bit, ready to get started in 2014. But unfortunately, in a very partisan environment we're in these days, Republican states have been quite resistant to these, despite the fact that this is actually a very conservative idea to let state governments actually control these health insurance exchanges and how they're structured and so on. And perhaps some of that comes from the fact that the federal government is already putting its stamp on a lot of these plans before they even get to the state level. So they're already saying, well, here are the benefits that you must cover. And for a lot of states or a lot of Republican governors, they may say, well, man, you've already weighed in on the most important stuff. What did you really leave for us? Just to kind of do your dirty work here or the mundane stuff? Well, it turns out there's still a lot of other things that states can do. Of course, they already have their own state standards, but they can also set up what the premiums should be. They can actually work with the federal government to administer the tax credit system. They can do lots of things, reinsurance program, on and on and on, or they can leave some of these things up to the federal government. There are a lot of operational aspects of these health plans that state governments might want to take on themselves. For example, since the state governments often interact with the health insurance companies in their state, they may want to really work with them on what how the plans should be structured in a way that's appropriate for their citizens. So, what citizens need in sorry, Mississippi may be slightly different from what they need in California, and how states go about pushing these insurers so that they structure their plans in a way that's more friendly for their citizens is something that is unique to them, and the federal government may not be able to do that very well. So leaving a lot of these decisions up to the federal government is a bit strange, and also educating your consumer base, right? So if these plans are going to be available and they're going to be run by the federal government instead of the states, then what does the federal government even know about your state, right? What do they even know about your state standards for health insurance, and how do they go about educating your populace? So it's a little weird to completely leave these up to the federal government when there really is so much of a state role available, and the states will have to be involved anyway because they certify which companies can sell insurance in their state. So even the ones that say they're not going to be involved, they really have to be involved in some way if health insurance plans are being sold to their citizens. They've got to play some role in this. Just some will play less than others. So there's a state-based option where states can control most of it, or leave a few things up to the federal government if they decide to do so, or they can just pretty much run the whole thing themselves. And some states are taking that option. There's a state partnership option where states say, well, we're going to let the federal government administer a lot of this plan, but we're going to help out with our consumers. We're going to do the educating our consumers, or maybe we'll help manage some of the plans and make sure they're appropriate for our state and that kind of thing. Then there's a federally facilitated option, where the federal government really just runs most of this thing. But again, states will have to play some role because they control health insurance in their state. So even though they may relinquish a lot of the sort of day-to-day operation of these plans over to the federal government, they may say, well, we don't want to set up the website for people to access these plans and that kind of thing. So the federal government actually goes about setting up the website and helping people determine which plans they qualify for and all that. The states will have to play, some role, and I think over time states will become persuaded to play more of a role as they look around and they see other states doing it, and they get some sense of, just how this is actually working for other states. I think over time they'll see that it will probably be useful for them to stay involved. Okay, so sorry. Here's where we are in terms of the state decisions. Right now, you can see that a lot of the western states have decided to create state-based exchanges. A lot of the Midwestern states are defaulting. Most of the southern states are defaulting. A number of Republican states, and sort of in the Mid-Atlantic and East Coast, Northeast area, you're seeing sort of a mixture of things going on, where states are really uh, kind of choosing various approaches, either completely saying we're going to be definitely a state-based exchange like Maryland, or like Virginia right now defaulting, sorry, to the federal exchange model, or something in between like West Virginia, right? I will say that some states are trying to come up with their own unique options, and this is happening for Medicaid expansion too. For Medicaid expansion, some states are asking, well, can we expand slowly, or can we? I think Arkansas asked if they have could receive the federal dollars for Medicaid expansion, but actually use them to enroll their citizens who would be part of the Medicaid expansion into the health insurance exchanges. So instead of having people be on a federal state program, they're going to just put them into the private market, right? So that actually I think is going to be allowed about the federal government. So there are really some interesting things states are trying to negotiate with the Department of Health and Human Services and the current executive branch in order to get really the deal that they want out of this. And I think that makes sense. I mean, smart states are not going to be locked into this partisan rhetoric. They're going to come up with solutions that are good for their people, and getting more of your citizens' health insurance, especially if it's not on your state dime, is a good thing, right? It just doesn't. There's really no reason to argue against it if it's going to help your citizens in some way. And providers are always going to argue for more coverage. So providers are putting a lot of pressure on states, as we talked about before, to expand Medicaid, but also to make sure that states get involved in these health insurance exchanges in some way. And I think you're going to see more of that kind of advocacy from providers moving forward. They're really coming to the table here, particularly hospitals, to really push their states to expand the number of people who have insurance in their states. So that's where we are now, and there's much more to come in the future. Okay, so thanks. I look forward to your posts. I know most of you have already started posting for this week because I'm putting this up a little late, and I look forward to the upcoming assignments that you'll be turning in over about a week and a half from now. Okay, take care.